All right, next up is Dr. Thomas Lewis with a big surprise. You will never guess what the hidden cause of heart disease really is and how conventional cardiology refuses to recognize this deadly burden. This presentation gets really interesting when you discover the single most unwanted organism that cripples cellular health, attacks living tissue, and negatively impacts the heart. And finally, it's easy to understand that contaminated blood is one of the greatest threats to the cardiovascular system. So please watch to the end of this presentation with Dr. Lewis as he outlines why this problem can cause nutrient deficiencies and heart damage. So, what is it?
What is it? The major cause of heart disease, huh? Well, is it a blood pressure medication deficiency? Is it a statin deficiency? Is it inflammation? That's where functional doctors go. But what is inflammation, Jonathan? And in fact, you caused me to write a book for the Immune Defense Summit discussing chronic inflammation. And Dr. Trent, my mentor at Harvard, the ophthalmologist who really connected the link between eye diseases and cardiovascular disease, would always say to me, Tom, inflammation is a treasure of nature. We've now learned with COVID-19 that we have an infection that leads to profound inflammation called a cytokine or bradykinin storm, but it's really highly elevated cytokines and inflammatory markers. So the inflammation can kill you, but it's chicken and the egg. What came first? In COVID-19, the infection came first. Cardiovascular disease, pre-existing cardiovascular disease, is the largest risk factor for dying from COVID-19. COVID-19 is an infection. Harvard Medical School is triaging, at Mass General, triaging in-hospital COVID-19 sufferers and trying to figure out who doesn't need help, who they can help, and who is a no-hoper. And guess what they're doing? They're doing very robust blood markers, not that the standard care, not anything that the standard care is using. Cholesterol is not a part of that test, so everybody's got a cholesterol test. It's not helpful. They're doing C-reactive protein inflammation. They're doing SED rate, which is clotting of the blood and inflammation. They're doing white blood cell counts, looking at low lymphocytes from the virus. But they're also doing viral serologies and bacterial serologies. So you could ask yourself, in COVID-19, the biggest risk factor is heart disease. Why is a Z-Pak, azithromycin, helping the treatment? It's a virus. Because everybody has a pre-existing burden of infection. So if you rephrase that question and say, what is it? I would say the number one cause of coronary artery disease, heart disease, is chronic infection, stealth infection. And another word for it in the medical terminology is ectopic, which simply means, why is this there? And the last one is cryptic. In other words, cryptic means, so like with Lyme disease, you could have been infected with Borrelia burgdorferi from the tick at age 10, and then you have some sort of manifestation of that when you're 50. No different than chicken pox. You had the chicken pox, but you develop shingles later in life when your immune system is crappy. So we have to recognize that we all have a burden of infection in our body. We all have a burden of organisms in our body, many of them beneficial, some of them commensal. Commensal, it's at some dose it's beneficial, at some dose it's harmful. I always tell my participants, if you have a really good politician and then they're in power too long and there's too much money, they become corrupt. My really good friend in Switzerland, Judith McCloskey, the world's #1 researcher in Alzheimer's, said, I rotate probiotics for that very reason. Good can turn bad, that's commensal. But then there are plain old, nasty, dirty, outright pathogenic substances, organisms, viral and bacterial. And my main focus in cardiovascular disease is intracellular, means they live inside cells. The flu is outside, you feel sick immediately, but intracellular bacterial pathogens. And the number one is chlamydia pneumoniae, and everybody says chlamydia, oh, I don't want to be tested for chlamydia, but it's actually mischaracterized. It's Chlamydophiliae pneumoniae. Chlamydophila pneumoniae. And this organism is a respiratory pathogen that at my age, and I won't give that away, 80% of people my age have been exposed to it. And the difference between those exposed and those who express symptoms is just the integrity of your immune system. Our white blood cells, for example, is your white blood cell count 0? No, because you need the patrol, the military, the militia out there taking care of these little wildfires before they take hold and go crazy. So we always have baseline immunity. And that's how I really tell if you have infection, is through the very simple test, a white blood cell count test. But yeah, this organism lives inside cells. You know, a mitochondria evolved. It's now part of our cellular structure, but evolved between a symbiosis between the cell and a bacteria. And so Chlamydophila pneumoniae, so that now is part of the organism, the cellular structure, but Chlamydophila pneumoniae can get inside the cell and mimic mitochondria and actually cause a cell to live longer than its programmed cell death, which is called apoptosis. Robert Horvitz at MIT, one of my colleagues, I like to call him a colleague, but you know he's uber. But he described programmed cell death. So every cell lives and dies. But when Chlamydophila pneumoniae gets inside the cell, it reprograms the genetic machinery of that cell and makes it cripple along on 3 cylinders, for example, so it can sustain itself. And then it's like the Taliban. It comes out for sneak attacks. It's not like the redcoats. The flu is the redcoats. You know it. You feel sick. But these organisms that can get intracellular and live in biofilms, these polymer-based, lipid-based structures like we have in the gum, like along the gum linings, you know, tartar, it's a biofilm. Biofilms are everywhere in our body. And so these organisms can live there, and they're literally vampires, and they live in the vascular. So I'm going to give you a concept, Jonathan. When you think about heart attack, stroke, that's a major vessel. I'm here to tell you that there's no, I'll be a little provocative, statistically there's no big vessel disease. It's all the disease of the small vessels of the large vessels, the vasa vasorum. So I tell my participants, I will guarantee you, if you answer this question right, you know more than 99% of the cardiologists out there. If you're at home and you have you're cleaning up some debris and you're rinsing some parts or whatever, and you have a sink, and one side of the sink, two-sided sink, has a very small drain, and the other side has a large drain, which one's going to clog first? And they all answer the small drain. I said, yep, you know more than 99% of the cardiologists, because every diagram in a cardiology office shows this plaque building up inside this large vessel. It's really building up in the small vessels that support the large vessel. You have to have a capillary within 3 cell diameters of any living cell. So a big vessel is wrapped with all kinds of small vessels, and the disease starts from the outside and works in. And all the diagrams show the disease is the inside. A cholesterol lands here and starts building up this plaque. It's completely wrong. This plaque comes from the outside and forms basically. I'll get very gross and graphic, like a zit. A zit is treated with antibiotics. Very profound acne, and it's the acne vulgaris bacteria that your body's immune system responds to and creates this little capsule of cytokines from the inside out. The same thing is happening in your vessels. Okay, I said it from the outside in rather. So this out here, where all the small vasculature is, gets diseased, and the cytokines aggregate and form this plaque inside now.
Well, again, though, physiologically speaking, the way you're describing it, the smaller vessels are actually more inside our body, and that's where the problem is developing, and it's spilling out to the outside or the outer part of a major vessel.
Right,
and
exactly.
that spilling out is what we see more, but it's not really where the problem is.
Right, and that's why Alzheimer's is underappreciated as a vascular disease, because it's happening at the capillary level, and tools like MRI can't see that. But, so chlamydophila pneumoniae is something that we all can be exposed to and actually share it. Just like COVID, we're wearing masks. And, but healthy people don't get sick from COVID. I had it back in early February. A doctor friend of mine that I do a lot of physical activity up in the Smoky Mountains with got it, and he had to be quarantined for 14 days. He had 0 symptoms. So it's like, we don't have to be fearful of some of these organisms that can cause heart disease, even periodontal disease. We all have a little periodontal disease, especially when you get older, but you don't necessarily die or have a heart attack from it because your immune system is controlling it. Naturally, you want to shut the faucet off. If you have periodontal disease, stop it. If you've been exposed to chlamydophila pneumoniae, it would be wise to get proper blood testing to see if it's starting to proliferate in your body, because organisms, if you got exposed to a heavy metal, that's it, and your body detoxifies, and hopefully you get rid of the source. But once one of these organisms gets inside, it can grow and multiply, depending on the milieu, the terrain, the health of your inner physiology.
So as we continue talking about this, Dr. Lewis, clearly then I would imagine your opinion is, if someone is told, wow, inflammation is the cause of your disease by a medical doctor, and that's all they say, from what I'm getting from you, it's too general, it's too broad, it's not specific enough. They should probably just find another doctor to work with.
Well, there's a continuum there. The traditional standard of care insurance-taking doctor is going to say your lipids are too high, your cholesterol. And cholesterol goes up. This is UC San Francisco. With inflammation and infection, your lipids go up. So we need to titrate to the inflammation. Then we need to titrate to the infection. A lot of functional doctors talk about inflammation. And certainly, when you do something that's anti-inflammatory and inflammation comes down, what you're really doing is you're supporting immunity. So your inflammation came down, but if you tested for the infection before and after, you would see that would come down too. These things aren't, these things are not death sentences. We're in a struggle, a war. It's war in there every day with these organisms. So it's all about the integrity of the immunity. But the challenging thing is, if you go in the standard of care and even get something as simple as a white blood cell count, they have a range of normal. It's like this, 3,400 to 10,800. It's normal. That's if outside of that, you have a high probability of being very sick. But, we talked about the concept of a health disease continuum. What about where are you on the continuum? And what we've shown in our research is we looked at things like white blood cell count, C-reactive protein, any number of markers, D-dimer, clotting factor, SED rate, red blood cell distribution. We can talk about some of these things. But where on the continuum of these biomarkers do they show a statistically validated increase in mortality? And when you do that, the normal ranges used in the standard of care get compressed to a very, very narrow range. And this is where we want to be. We want to be in this narrow range, not out here on this continuum. So
again, to crystallize though, before we jump off too much to something else, for someone just listening to you about white blood cell count alone, why don't you talk a little bit more detailed about that? Obviously, too high a white blood cell count, I know I'm simplifying things, but for the sake of understanding this, it's too high, it's driving up inflammation, but again, it's not really explaining to someone what's causing the inflammation, what's causing the white blood cells to go up too high. Maybe you want to talk about where it's more of a safe range to be for just white blood cell count alone?
That's perfect, Jonathan. And white blood cell counts are so clear. You go to Wikipedia, Mayo Clinic, why do they go up, but why do they go down? And it's always infection. They go down in viral infections, they go up in bacterial infections in general. I'm simplifying it. But when you look at it, when you have a chronic infection like gum disease or chlamydophila pneumoniae in your vessels, it's probably not everywhere. It's the concept of focal infection that Charles Mayo, the founder of Mayo Clinic, first talked about over 100 years ago, and has actually been known for like 300 years. But let's just take, rather than chlamydophila pneumoniae, which is in the vessels, let's just talk about gum disease because it's a little more easy to understand. We understand this part of our mouth, and if there's some infection in there, when it dribbles out and the white blood cells come to help, then you're not going to have like flu-like white blood cell counts, wicked high, as they say in Boston. You know, it's just going to be slightly elevated. So optimally, you want to be between 4,000 and 6,000 white blood cell count. Anything above that, you probably have a chronic infection going on. In fact, if you really want to be super optimal, it's 4,400. I've seen enough clients to know that it's 4,400. So let me just give you how profound this knowledge is, even though it's not being used in practice, because we're only focused on reactive acute care in the medical community. Here's the Women's Health Study and the Nurses, Women's Health Initiative and the Nurses Health Study, conducted by Harvard, but overall over the whole country. 138,000 women monitored prospectively. And they showed a very simple thing. If you take two groups of women, one with a white blood cell count of 4,700, normal, and one with a white blood cell count of 6,700, normal. Abnormal is way out here at 10,800. And you follow them for 6 years, 50% more of these women are dead, 6,700. So what we've shown through our research is that the earliest sign of an increase in mortality from white blood cell count is actually right around 5,800, and the indication that goes up is cancer mortality. But the only thing I'll tell you is that you shouldn't just get a white blood cell count, you should get a white blood cell count with differential. There are 5 types of white blood cells, and the white blood cell count is the aggregate of all 5. But what I look at specifically are your neutrophils and your lymphocytes. Neutrophils are the most common, lymphocytes second most common. Neutrophils go up generally with bacterial infections, and lymphocytes go down with viral infections. So now your white blood cell count is normal, but your neutrophils are high and lymphocytes are low. Guess what? You have confounding comorbid infections. You have both viral and bacterial burden. And, looking at neutrophil percent, anything above 60, bacterial. 40 to 60 is probably the normal range. If your lymphocytes are 1,000, that's too low. That's what they're looking for in COVID. Lymphocytopenia, low lymphocyte counts from viruses. So it's really simple, but it's also no fool's game. That's why, Jonathan, you forced me, I'll shamelessly promote, you forced me to write this book for the Immune Defense Summit, and you even named it, Uncovering Chronic Inflammation and Hidden Infections. In this book, I explain most of these pathologies and how you study them. But I think maybe the most interesting one of all, and highly misinterpreted in the standard of care, is your red blood cell distribution width, which comes with a complete blood count with differential. And what a red blood cell distribution width is very simple. It's the life and times of a red blood cell in your circulatory system. And a red blood cell, we know from A1C, because A1C is a complex between glucose and a red blood cell, is around 4 months. So a red blood cell lives for about 4 months, and it's born small and dies large. Why? Because going through corroded vessels literally inflames the outer membrane of the red blood cell, and it gets larger. So the red blood cell distribution width is literally telling you how beaten up that red blood cell, like it's us going through a hazing. We're getting slapped around and we're getting beaten up. And it literally tells you how plaqued, inflamed the inside of your capillaries are. It's very simply why if a capillary is this big in diameter, a red blood cell is this big in diameter, and to go through a capillary, a red blood cell literally has to exude and squeeze out like a worm going through soil, and it's really in contact with the outer vasculature. So what we use 2 measures. C-reactive protein, which tells you how inflamed the membrane is, and then the red blood cell distribution width to sort of show that the two are working together to see the distribution. And the number one thing that's causing the inflammation in this vascular lining is the organism Chlamydophila pneumoniae.
Wow, we're talking about infections obviously being the hidden major cause of heart disease, and it's just blowing my mind as I'm listening to you. All of these infections, wherever they may be coming from, what you're mentioning now, Epstein-Barr, Lyme disease, all of these different infections, gum disease, mixing with the blood, mixing with the saliva, down into the gut, then throughout your whole bloodstream, all of this is causing sticky blood. This is what you're describing as how sludgy or difficult it is for our blood to circulate, and no doubt that's causing cardiovascular stress on our whole system, month after month, year after year.
Yeah, let me just digress to the red blood cell, but I'm going to talk about SED rate and how it's a surrogate for the electrical system. But RDW is used, red blood cell distribution width, for anemia, and usually your RDW is 18 or above, and 25, 30, you're anemic. Okay, but above 12.5 to say 16 or 18, that's telling you the degree of inflammation inside your vessels. And so it's a very important distinction between anemia, which really affects the red blood cells, and internally versus externally, the beating up of the outer membrane. But you're talking about sticky blood. One of the most complex people that we deal with in our practice with my medical doctors is a high SED rate. And SED rate's very simple. It's how much platelets in a tube of blood will settle and expose clear plasma. Our blood is fluid, so there's clear plasma, and then there are the platelets. Your red blood cells should defy gravity. Everything is, their physical structures, so everything's being pulled by gravity, so why don't they settle? Because the membrane is charged through the sodium-potassium pump and through ion channels creating an electrical charge. Every cell in our body is basically a little battery. A lead-acid battery, flow of ions. Ions flowing in and out of membranes. Cholesterol is a very important part of that. We'll talk about that later. But the flow in and out creates the charge. Now there's a repulsion. So when you have a high SED rate, you have sick blood. More importantly, the cellular nature of those blood cells are discharged. And I can guarantee you every other cell in your body is discharged as well, because the lipid bilayer is contiguous to all cells. So you have very poor flow, very poor membrane structures, very poor nutrition, any number of factors. So when you can improve a SED rate, and now in the standard of care, the SED rate is 0 to 20 or something like that, sometimes 15, sometimes 25. You want to have a SED rate of 2. I put 0 to 6. I don't see an increase in mortality at 6. But really, with a LabCorp Quest SED rate test, which is dirt cheap, it's an old doctor test. You could do it on your bench. Didn't even have to send the thing to the lab. Just put the test tube on the counter and come back in an hour and see how much was settled with just its millimeters. So when I say 20, it's 20 millimeter settling.
I'm sure you're familiar with this, Dr. Lewis, but it's interesting what we're talking about with red blood cells. We're talking about how, yes, of course, we have to take care of infections and minimize that risk, clean it out of the body, keep it as low as possible, keep our immune system strong so that we are reducing the risk of inflammation, sticky blood. But they were talking about how many people are not grounded. Years ago, I saw the grounded studies where they would electrically ground somebody, their feet, to the soil, to the grass, to a sandy beach, just to be grounded electrically, and how within 45 minutes to an hour, they literally started to see the red blood cells. They were sticking together, and really, you didn't have to have a major degree. Sticking together, clumpy, disgusting, and then after 45 minutes to an hour, bing, the red blood cells, like what you were talking about before, they just started to get more circular and floating around and looked so much healthier and more vibrant just by changing that alone. And how many people are fully infected in their body, not addressing that, and not grounded to the earth at all. They're messed up electrically too. You've got so many confounding factors that make the body so sticky and sick in the blood.
Well, I think that's a really good point. And, Jack Cruz, who recommends you go to the beach and stay in the water because, the salt water is a conductor. And you're also absorbing some nutrients and minerals through the skin. But the number one thing, when I look at a high SED rate and everything else looks pretty normal, I'm saying the person's just having an absorption problem in the gut. A little constipation, it's easy to absorb carbohydrates. It's difficult to absorb minerals. You have to have good, strong acid. So you have constipation, you probably don't have strong acid. You have a high SED rate, you're not getting mineral absorption. And it's the minerals flowing. The Khan Academy has some excellent videos that are highly technical on healthcare. And so you look at the sodium-potassium pump, watch one of their videos about how, sodium opens up the channel inside a cell, potassium opens it outside. So guess what? If you're potassium deficient, your cells are going to be bloated. You're going to retain water. You're going to have high blood pressure, and you're going to have a high SED rate. It's very simple physiology. It's just osmotic pressure, basic things. But how do you fix it? You improve leaky gut. You improve improper acid. You improve the microbiome. You maybe help support some of the digestive enzymes for a little while. You take some really good probiotics, prebiotics, and normally that stuff will clear it up.
Where we're talking about solutions now towards the end, which I think anybody listening carefully to what we're talking about here already, they figured this out already. But here it is, you just mentioned at the end, constipation. Again, it's not a fun topic to talk about. A lot of people don't like to talk about it with their doctors. Most doctors aren't talking about it nearly enough. If you're constipated, your gut is backing up and you have all this, literally, crap inside, which is actually being kept outside your body, in your intestinal tract. It's constantly attacking the walls of your intestines. Now you get this thing that a lot of people are familiar with leaky gut. That's where the infections get inside the body. And so the story goes for somebody for years and years, compromised immunity, constipation, dehydrated. We talk about these problems. The solution is really just doing the opposite, fixing these things.
Right. Yeah, it's not a deficiency of some medication. But, we talked about chlamydophila pneumoniae as the major infection that underlies a lot of the vascular diseases in people. And I would say when I screen people with a white blood cell count that's just slightly off, 50% of them test positive. And what I want to tell you is that testing for these organisms is available at the major labs, LabCorp and Quest. Just people aren't ordering them and don't understand how to interpret them. I think COVID's helped a lot understanding the difference between IgG and IgM. IgM is the immunoglobulin that's sort of looking at the acute phase of the infectious process, where IgG is looking at the chronic phase. And a lot of doctors will tell you, no, that was historic, you no longer have that. But Dr. Tremp, my eye mentor at Harvard, you can see Toxoplasma gondii, which is an intracellular parasite that develops a scar, can develop a scar in the eye. You can see it's called a toxoscar. And when you test a person with a toxoscar, their IgM is normal, but it's negative, and their IgG is elevated. So that means you had it. But when you take that toxoscar, which you can access in the eye, and put it in culture, it grows. So it's not, IgG is misinterpreted as a past infection, but really what it is a dormant. You think think the chicken pox is the only thing that can go dormant? These organisms are clever. They all can go dormant. They go into actually 3 phases that Charles Stratton at Vanderbilt articulated extremely well: an elementary body, a cryptic phase, and a reticulate body. So they live in different phases. And unfortunately, if they really start proliferating and you have profound disease, then reversing that is a long and tedious but doable process. So just to give you an idea, I can do a chlamydophila pneumoniae blood test IgG titer for the same cost as a lipid panel. We were discussing how organisms like periodontal disease, from periodontal disease, chlamydophila pneumoniae is the one I focus on, not exclusively. Usually if you have one infection, you have comorbidity because it took hold just because you had a weak immune system So anything opportunistic that you've been exposed to and is living dormantly in your body can take hold, but chlamydophila pneumoniae tends to be the one that I see the most. And, if you're out there and you don't have a doctor to do a chlamydophila pneumoniae test, how do you know whether you have a chronic infection? How do you know your arthritis, your psoriasis, your mood disorder, your vascular, your angina is caused by an organism like this? And simple standard blood testing will reveal the truth if you know how to look at the ranges. So what we've done to improve upon that is we've created an algorithm we call your chronic disease temperature, which takes 21 biomarkers that we've looked at exhaustively for where the biomarker shows the first instance or inkling of an increase in mortality based on peer-reviewed studies, and amalgamated into a single score. And I think that's appropriate because, you, Jonathan, if I met you and talked to you for 5 minutes, I'd know a little bit about you, but I don't know your story. It's like if I look at your C-reactive protein, it's an acute phase reactant. If I bang my toe, it'll go up and it'll come down. I don't have the full picture. I have a little snapshot on it. So it's really important to know how to interpret labs, not from, oh, Mrs. Jones, this is your C-reactive protein. Oh, this is your lipid. Oh, it's how they all work together to tell a story. So, the red blood cell distribution within the C-reactive protein. One is inflammation in the vessel. One is inflammation on the red blood cell traveling through that vessel. Fibrinogen. It's a signal molecule that will recruit repair. If you cut yourself, fibrinogen will go sky high over 500. But if you just have inflammation in your vessels, fibrinogen, my endpoint for that on the high end is 285. So if it's 300, you have more repair and recovery than someone with a fibrinogen level of 250. And they usually track. C-reactive proteins, 3.5. Red blood cell distribution width is 13.5. Fibrinogen is 350. Now I have not the string quartet, we have to add another one, insulin. Insulin is probably, we measure metabolic diseases with glucose and A1C. The disease is insulin resistance. So insulin goes up first before the glucose goes up, before the A1C goes up. And as you know, Jonathan, from your metabolic summit, is that sugar in the blood is a major risk factor for inflammation and cardiovascular disease. But it really is a sign, what I say is elevated insulin is a barometer for malnutrition. And malnutrition is titrated back to repair and recovery. We all have wear and tear. It's just how good our repair and recovery is. So insulin will be up, C-reactive protein will be up, red blood cell distribution will be up, fibrinogen will be up, and oftentimes your sedimentation rate will be up. And the other things we look at, particularly for inflammation, is uric acid. Uric acid, gout. But uric acid, if you went to the top of Pikes Peak, 14,000 feet, your uric acid would go sky high. It's protective at higher levels for hypoxia. But if you're at sea level and just a regular run-of-the-mill guy eating a fairly good but not very good diet, and your uric acid is up, there's probably some hypoxia in your microvasculature. That's what uric acid is telling us. We look at lipids. We need to embrace the dark side of healthcare. And when your lipids are optimal cholesterol, and it's really a total cholesterol, which is LDL, HDL, and free cholesterol, is really optimal at around 220. That's what the international studies show, lowest risk for mortality. But when you have someone with a HDL of 70 or 80, then that's a very healthy person at 200, 220. So we look at cholesterol as a biomarker for vascular risk when you don't have familial cholesteremia, hereditary high cholesterol, when you're over 300 and when you're below 160. No one's talking about the low end of the curve, but we'll talk about that next time. So cholesterol is part of our algorithm as well, and we talked a little bit about the neutrophils, which is a subtype of white blood cell count, but just the neutrophil percent is extraordinarily telling for infection. in the lipid arena, it's not your LDL, it's not your total cholesterol, it's the atherogenic index of plasma, which John Hopkins has published on and published in the Mayo Clinic Proceedings. And that's the ratio of your triglycerides to your HDL. It's actually the log of that. And so really what it's saying is that if you have high sugars, triglyceride being a surrogate for that, and low fat transport, that's what HDL is doing, high density lipoprotein, it's a taxi cab for fat. So basically what it's saying is you're extraordinarily sugar dependent, then you're inflamed. And when you're inflamed, you're malnourished. And when you're malnourished, you're susceptible to infection. There's almost no one I've tested that's diabetic that doesn't have a subacute infection, slightly elevated white blood cells, things of that nature. So those are the major markers that we look at. We look at kidney function. It's a shame right now that they publish, greater than 60. You're okay. You want to be between a 90 and 120. Once again, kidney function is on a continuum. And if your kidney function is below 90, there's very simple cleansing things you can do to restore your kidney function. Your kidney, you're talking about heart disease, the most vascular tissue in your body, not a lot of blood, but it's so robust in terms of blood flow, is the choroid of your eye. The second most vascular is your brain. There's the carotid arteries supplying blood to your brain. The third most vascular is your kidneys. And the kidney dictates, with cooperation from the brain, what your blood pressure needs to be to support what? Your brain, because it's so vascular. And your eye, because you need to see to survive. Things of that nature. So that's really what I want to talk about here is we need to understand the story of what your labs say. We produce a very detailed color-coded report called your chronic disease temperature, where we give you a single number for a constellation of labs. And that makes it very easy to track. Is what you're doing causing your chronic disease temperature to go up? Stop doing that. Is your chronic disease temperature coming down? And I think you should take it every 6 months. We're dealing with chronic conditions, and so these are things that you're going to mitigate over time. It's not trying to knock out the flu.
Yeah, it makes perfect sense. Just change your lifestyle, a healthier lifestyle, reduce these, I say, hidden infections, but they're not hidden anymore. Everybody's learning now from you what to look for, and then these numbers will change in a favorable way, and you don't even need the toxic medications.
No, and the blood labs provide objectivity to the subjective things you're doing to improve your health. So if you really want to have a barometer of, are you on the right path? Is this weight loss diet right? Or is this detox program right? Your blood doesn't lie. I didn't write that book, but it's a fantastic book on looking at blood labs, but it's very true.
The numbers don't lie.
The numbers don't lie.
It's great. Thank you, Dr. Lewis.
My pleasure.
Up next, as promised, I'd like you to meet an extraordinary holistic cardiologist, Dr. Lowell Gerber. Dr. Gerber completely changed his medical practice due to his own serious heart health issues. And at the beginning of our conversation, Dr. Gerber describes how a heart attack patient literally saved his life. In addition, most people never hear how systemic infections like Lyme disease can threaten heart function. So today, you'll find out how unwanted stealth pathogens are more dangerous than high cholesterol. And finally, there's a big difference between bad genes and a genetic tendency for disease. Dr. Gerber will outline the most advanced testing protocols to uncover your risk of heart failure. Enjoy this presentation with Dr. Lowell Gerber. So, Dr. Gerber, thank you very much for coming all the way down from Maine through to Mexico. It's a long story. People will definitely hear about that in the next couple minutes, but I appreciate you being here. Thank you.
Thank you. It's a privilege to be here with you.
So let's talk a little bit first about your journey. A lot of people may not be familiar with your work, and it's amazing our conversations we've already had off camera. Where did it all start for you? Because I know you're trained in conventional cardiology, and I often ask a lot of doctors, what the heck made you focus on holistic cardiology?
Well, I think, like many of us who work in the field or practice holistic medicine, holistic cardiology, holistic healing, we start in it because of our own journey. And I had been a pretty healthy young man. I did long distance running in high school and college, did triathlons till I was in my mid-50s. And then I started to fail. And when I started to fail, I was at a medical school, at a faculty position, and I saw my chief of cardiology and then the internal medicine doctor who did preventive medicine, and we talked about it. And basically he wanted me to take weight loss drugs, had to get on a statin, an ACE inhibitor, take aspirin. And I did those things, and I followed the recommended diet, which was low-fat American Heart Association recommended diet. And I gradually got worse. And for me, the eye-opening aha event was when I was on call. I did interventional cardiology, and I was on the angioplasty team. So if there was an acute MI, we'd get called in, and we would meet the patient very often. He'd been through the emergency room, been worked up, and we got to introduce ourselves on the cath lab table. And sometimes my introduction was basically seeing this of the patient was a little opening, little oval opening over their groin, and I'm trying to talk to them although they're sedated, and there's an image intensifier tube in the way, so it really wasn't very personal. And so often I really didn't see the patient, know the patient, until the next day. And so this was a young man in his 30s, ex-military, out of the in a civilian life for about a year, and was training bank security officers at midnight to 3 o'clock in the morning on security protocols. And he had his heart attack. It was like 1:45 in the morning when they brought him into the emergency room. They called me to come to meet him. And it was one of those things where he's having acute anterior MI, you put the stent in, slap yourself on the back, oh, I saved this guy's life. You slap him on the thigh and say, I saved your life, and then you see him the next day, and at that time they were going to a really short hospital stays. So if you got to them early, they'd be out of there 24 to 36 hours later. And they would get a stack of papers, take an ACE inhibitor, a beta blocker, statin, low-fat diet, go to cardiac rehab, stop smoking, and we'll see you in... That was their cardiac teaching. So it'd gone from, when I was training, a cardiac rehab program, the patient was in the hospital for a week or 2 weeks, and then, not anymore. It's just a stack of papers and you're out of here. So I saw the guy for his follow-up visit, and he said, Dr. Gerber, I don't know what's going on, but I was really trim and fit when I had my heart attack, but now I've got a little bit of midriff bulge that I didn't used to have. And I said, well, what's going on? He says, well, I'm following what they told me to do for cardiac. I'm eating their diet. I'm doing their cardiac outpatient rehab program. He said, it's not very much. He says, I'm used to really working out, and now I'm just kind of taking a little gradual walk. And I said, well, how about weight training? He says, oh, can't have it. Can't do that. So I said, okay, just make sure that you're following the guidelines, and I want to see you again in a month and come back, and I want you to bring a food diary with me. I want to know what you're eating. I want you to bring your exercise log, and I want to see what you're really doing, and I want to make sure that you're keeping with the guidelines. Remember that? Keep with the guidelines? So he comes back. He's gained a little more weight. I look at his labs. His blood sugar is not diabetic, but it was really... Initially, it was pretty low. Now it's up a little bit. His cholesterol's really not perfect. It was a little bit high. And he gained a little weight. And he had a little bit more of a bulge. And I said, you really ought to get with the guidelines because, you're going in the wrong direction. And he says, well, Doc, he says, here's my log. You can see my exercise log. I'm doing exactly what they told me. He said, I'm not doing more. I'm doing exactly what they told me. Here's my food log. You can see what I'm eating. I'm right on schedule. I'm doing exactly what they told me. So it was at this point in time when I wasn't doing so well, and I went to see my doctors, who told me that I need to get on the, because I had been doing triathlons, and I had been following a Mediterranean diet, and they said, no, get all the fat out of your diet. And so I was doing everything my doctor told me to do, and I gained a little weight. My blood sugar was not quite as pristine as it was. I was feeling really lousy. And this guy's saying, I've gained a little weight. You doc, you're telling me my labs aren't so good. I'm thinking, oh my God, I'm like him. I'm doing exactly what I'm told to do. He's doing exactly. And I said, I felt terrible because all my life I've been telling patients that they're not following my advice, and that's why they're getting worse. But they were getting worse because they were following my advice. And that was the aha moment. I said, there's something wrong here.
So then what happens then? You started looking into holistic cardiology interventions all on your own?
Well, so I started to figure out, why is my body different? Why is my body, so I'm thinking, well, the guidelines are right, but there must be something wrong with me. So I started to look outside the usual dogma. And I started to find out that, well, because I had been following a really strict, low-fat, almost vegetarian diet when he told me I needed to do that. And there's, the Barnard Group, Physicians for Responsible, whatever. I started going to their website and listening to their lectures, and nearly vegetarian. But I started to read opposing opinions. And then I realized that maybe I was following the wrong advice.
So we're going to get into a lot of these things, Dr. Gerber. Let's start from the beginning for people who I know are going to get a lot from this conversation. Defining what you mean by a toxic heart.
So that's another thing that I stumbled upon partly through my own journey. And a toxic heart can mean several things. So I personally was disabled with neurological Lyme disease. There was a point in my life when I could only work a couple hours a week. And I had excellent state-of-the-art Lyme doctors, and they prescribed antibiotics, and I got better, but I couldn't get across the finish line. And I was very lucky that I worked with a woman who was a healer and had a completely holistic theory of body mechanics, and not only body mechanics, but studying how tissues respond to injury and inflammation. And I actually wound up doing research with her. And I would see patients come into her office on crutches and wheelchairs, and then a few months later, they were up walking. And at that time, I was helping her with imaging. She developed a technique where you could image tissue metabolism. It wasn't heat, it wasn't sound. She could measure the frequencies coming off of muscle, nerve, artery, lymphatics, and each tissue would have a characteristic frequency, and if it was injured, if it was tension, if it was infection, other types of inflammation or congestion, it would give a different signal. And she worked with folks at MIT, and there's a little device that record these signals. So I was interested in it. I was correlating medical imaging. I've done nuclear, echo, CT. I was partway trained in MRI. I never finished it, but certified in CT, and she wanted to correlate her findings with medical imaging. So I went to her then as a patient, and that got me thinking that she's doing something much different. She introduced me to heat shock proteins and far infrared and ozone and things like that I'd never heard about. And if you look them up on QuackWatch, that's all quackery. So that got me interested in another aspect of it, and I started to get better. It wasn't until I went to the clinic in Mexico that I really turned the corner with real holistic medicine. I mean, the combination of herbal therapy, energy therapy, and we'll talk about those later. But that's what turned the corner for me.
Was it just Lyme that you were dealing with, or were there other health issues too?
Oh, so, I mean, I'd been doing triathlons and still I started to get sick. So I was living in Florida, and there was a baseline element of mold that I just didn't recognize. And then I bought property in Maine to develop a medical retreat, and it was raw land and forest. And in the process, I got multiple tick bites. And I was a cardiologist. I had no idea about what ticks were. But I got a number of bites. I'd go to the urgent care center, and they would pull them out if I couldn't yank them out myself. And I'd ask about antibiotics, and they'd say, well, how long has it been on there? I said, well, I've been working on the trail. I created a nature trail with an herbalist to identify edible and medicinal herbs, shrubs, trees, plants along the way. So I got all these bites, and I was never given antibiotics because they told me I didn't need them. And I never had a typical bullseye rash. I had a little inflammation. But so along that journey, I started to get even more sick. And eventually was at a point where I had a recommendation to have my surgery on my cervical spine because I had been wearing a lead apron doing interventional cardiology for so many years. And I was having paresthesias, muscle weakness. It really didn't explain some of the mood changes and emotional things, but they all thought, well, because you've got all this pain and disability from your cervical spine, all these other things, you're depressed. It's all in your head, all those other things. And I saw a therapist who recommended that I get evaluated for Lyme disease, so she gets the credit for the diagnosis. And I went to see a Dr. Ligner in New York, who's world famous Lyme doctor, and he introduced me to doing a thorough history. And in the history, he recognized I'd lived in Idaho and had camped and rode my bicycle and did horseback riding in the Sawtooth Mountains, where there's another type of spirochete it's called Hermsii, Borrelia hermsii. So I had Borrelia burgdorferi and Borrelia hermsii. Then I also had Babesia, Bartonella, Ehrlichia, and the typical mycoplasma and some heavy metals. So I had the full gamut, and that's what really caused my problem. And then, so taking antibiotics wasn't going to work because I had to take rotating antibiotics for multiple organisms. Bartonella doesn't necessarily respond to the same thing that Borrelia does, and the same thing for Babesia. So this is where I learned that trying to kill multiple organisms with antibiotics, anti-life. So in that process, I had some other things going on in my life, and I got a very worrisome message while I was at a shopping mall, and very stressful. And I developed chest pain. And I'm thinking, well, it's just the emotional response to this. I can't have problems with my heart because I've been doing all these healthy things now for so long. My father lived till he was 94. So I didn't think at all it could be heart problems. But then I went to see my friend, the therapist, who diagnosed my Lyme disease. And I just told her, I'm having a bad day. I'm under stress. I'm having this chest pain. And so she listened to me and she said, well, when was the last time you heard a story just like yours? I said, oh, it's a while back when I was in the cath lab taking care of me. And she said, you better go see a cardiologist. So I couldn't believe, I couldn't believe that could be me. So I actually was in Maine. I made reservations and went to New York to see the guys who trained me in coronary CT. That's what they do. They're experts at it. And so I wasn't going to have just a stress test. I was going to get the answer. So we had this coronary CT done. And so I'm board certified in coronary CT. I'm a level 3. I can train people. So I've seen a lot of it. And I'm looking at them with them. I said, that doesn't look like, to me, it doesn't look like a typical stenosis. It looked to me like a piece of bubble gum kind of sort of wedged in there. And they said, well, it's really hard to tell. It could be just atherosclerosis, could be ruptured plaque, could be a lot of things. I said, well, I think it could be biofilm because I've got all these organisms that that caused biofilm, and I think I was really under stress and maybe had some, so I gave them this theory about Lyme and co-infections and the heart, and they said, we've never heard of that.
Let me stop you for a second, Dr. Gerber. And I don't know. I'm not an expert. You are. When you go, like I've mentioned in other conversations I've had for this docu-class, when you go on the main websites to search for information about what the heck is causing my heart problems, literally 2 sentences, maybe 3 from my memory, it says heart infections. And when I was listening to you, I hope a lot of people, we didn't lose them. You're talking about Lyme, you're talking about all these buggies, you're talking about walking on trails, you're talking about bugs biting you. What has this got to do with my heart? But yet on all the conventional sites, Mayo Clinic, you name them, they talk about heart infections, bacterial, viral, and parasites. And then that's it. They don't give people more information. There's this relationship, there is that connection. Can you explain it a little bit?
So that's exactly what I'm kind of leading up to. So I looked more into that, and so I have a theory that infection and stealth infection inflammation is probably more of a factor for heart disease and heart attacks than cholesterol. In fact, if you look at the World Health Organization statistics collectively, for women, the higher the cholesterol, the better the survival. And for men, it's almost neutral. So there really is no correlation between heart disease and cholesterol. And I looked a little further, and so yes, there's actually a microbiome in the plaque, and there's a microbiome in clots associated with heart attacks. So there seems to be some association with it.
Just to interrupt you for a moment, though, and go back over something that someone might be going, what did you just say? Didn't the Framingham Heart Study, same idea as well, to be very clear about what you just went over very quickly? That people would say 220, 230, 240 cholesterol, oh my God, it's terrible, you're heading towards a heart attack and serious heart disease. But then there's people with 170, 150, 160, 180, and there's no direct relationship. The lower you go with your cholesterol, the safer you'll be with your any kind of heart concerns. That is simply not backed up by science, correct?
Correct. Half the patients who come in with a heart attack have a normal or lower cholesterol. Patients with familial hypercholesterolemia, before we started drugging them, they had an advantage to survival. And the data is coming out now that it's not the cholesterol level. These people, some of them have a propensity for thrombosis. And so it's those people who have the thrombophilia who are at higher risk.
So it's interesting, for sure. At least we made that point really clear, Dr. Gerber. Let's go back, though, sorry to interrupt you, about the idea of the bacteria now, viral or bacterial infections, the biofilm that can develop. Talk about that a little bit more and how that's related to a toxic heart.
So there's actually literature out there that shows that what's called the infectious burden is associated with mortality from heart disease. So the infectious burden includes viruses and bacteria, typically when they've been studied, or they'll look for serology for different viruses present in the body. And it's a fairly good correlation. So the question comes up, well, just because you find all these organisms, a higher infectious burden, does it mean that there's a causation? And that's always been the difficulty. For example, chlamydia have been found frequently in lesions in coronary arteries and other vessels. And it's been difficult to prove by giving them antibiotics that it actually changes the course. But there's some theoretical problems with giving antibiotics in a situation such as that, because there are other factors that play a role. And so it's not proven yet. There's a lot of associated data to make it suggestive, but it's not proven.
Right, and this is the issue with conventional wisdom, if you will.
Yes.
Is correlation versus causation. This whole idea of they poo-poo all of these ideas. But this is something very significant. And also you mentioned antibiotics. not always will even antibiotics effectively handle these infections because of a biofilm that's
Exactly.
stopping it from penetrating and doing its thing. But the fact that it's always seems to be around with people who are sick, Epstein-Barr, Lyme, all these things that fester for years and years and years. Infections in the mouth, which we'll talk about a little bit later on too, pouring into the blood. It's blood toxicity that's really making for a toxic heart, right?
Exactly. So it's really a toxic body, and the heart is really connected to the body. Now, when I was a cardiology fellow, and my buddies who had gone through internship and residency with me, some of them became pulmonologists, and they would laugh at me, said, the only role of the heart is to hold the lungs together. Or my friends who went into neurology said, well, the only role of the heart is to pump blood to the brain and to act as a sewer from the stuff coming out of the brain. But they're all connected, and they all have a role. So yes, so in order to, and we'll talk more about that, to detoxify the heart, you really have to detoxify the body. But what
I think also what you're saying is so significant even to this day, that conventional cardiology, probably without even intentionally making a lot of effort in that direction, is taught that the heart is just this mechanical thing inside the body that does just pump blood, and that to make this connection, that the things that people do and the presence of things somewhere else in the body, or how we eat and how we live and how we think and how we feel, affects even the nature of our blood, and over time that's going to affect the condition of our heart. They don't get into any of this kind of stuff.
Yeah, so the traditional view of the heart is a heart as a pump with valves in it. But when I look at the heart, so as a medical student, I did research with a pathologist, and our research had to do with blood vascular reactions, so inflammation in the blood and what it did to the endothelium. And so we looked at the lining. The endothelium is a very small, thin, single-layer lining of every blood vessel in the body. But they're different. So the endothelium in the lung is not the same as the endothelium in the kidney, and not the same as the endothelium in the liver. So they all have different responses to inflammation and infection. And we used endotoxin. So endotoxin is a substance that is released from bacteria when you kill them and disrupt them. And endotoxin causes inflammation throughout the body. So one of the ways that we would study the effects of inflammation in the heart and the lungs would be to ligate the cecum in the experimental animals. So yes, the bowels were connected to what happened in the heart, in the lungs, in the kidneys, in the liver. And that's not a traditional view. So when I look at the heart, I not only see contractile elements in the muscles, but I see a huge network of tiny little blood vessels throughout the heart. And each of those blood vessels has endothelium. And so organisms such as Borrelia and Bartonella, they live inside the endothelial cells. So the heart becomes a target. So the heart, it is a pump, and it has to pump continuously, 24 hours a day, but it's also a generator. It has to generate electricity 24 hours a day, 7 days a week.
You were just reading my mind. I hope we're not losing people in this kind of a conversation, but something just popped into my head as I was listening to you speak. The idea that we're focusing right now on infections that fester for a long time, and they're causing problems in your digestive system, they're causing problems on the inner lining of the plumbing of your body, the blood has become more and more sick, inflammation is happening, and again, conventionally speaking, none of this is talked about. But the fact that everything you're describing, mechanically even, just being infected for a long period of time and not effectively dealing with it, then changes the way we energetically or electrically behave, that our heart would actually change the way it's functioning depending on this toxic or less toxic fluid that keeps flowing through our body all the time and then affects literally every physical piece of matter leading up and through the heart all the time, right? It would really affect impulses.
Exactly. So we're getting down to what's a toxic heart. I mean, so I'm starting out with the toxic body and working our way down in toxic blood. We're going to work our way down to what's in the toxic heart tissue, and then we'll get down to the cellular level, is where the action is. So we really haven't touched on it. I don't want to dwell too much on it right now, but there are other things that make the heart toxic besides the infections, or heavy metals, lead in the environment, mercury in the environment, mercury in amalgams, and the mercury in our teeth. Those are very toxic. And I'm going to jump just for a second from mercury to antibiotics, because back years ago, mercury was a very effective antibiotic for syphilis, for example. And it's all natural. Mercury is all natural. But it's also very, very toxic. So we use a lot of antibiotics. Some of them have natural origins, actually, to treat infections, but they also have a toxic effect on the heart. And there's a lab test that I use from a laboratory in Germany, and we can ask them to identify antibiotics that are in the cell, in the nucleus of the cell, and attached to chromosomes. So people who've been through some of these regimens for chronic infections, whether it's acne, they've gotten many, many years of antibiotics, or from Lyme disease, where they get sometimes many years of multiple antibiotics, you can actually see how the antibiotic is damaging the DNA and damaging the mitochondria.
This is already huge. You're blowing my mind already. I'm just thinking about all the people listening to us right now. Colds, flus, any kind of infections that are just there are millions of people taking antibiotics for completely different things, Jonathan. What does one thing have to do with the other, Dr. Gerber? I was treated a year ago for this thing. What has this got to do with my heart? But everything you're saying about antibiotics and what it does to the body and how it affects our gut and then our ability to absorb nutrients from the food every day that we eat. I mean, there's such an interconnected relationship here that I feel like a lot of people, that's why I love this conversation already, don't appreciate how disconnected so many people are from all of this information. That's why it's so hard for people to figure out, how did I get to this place where I have cardiovascular disease?
Yep. So now I don't want people to misunderstand me and think that you shouldn't take antibiotics for any reason. Getting back to my origins and interest in this was from Lyme and the effects on my brain and on my heart and my body. So people ask me, I get phone calls out of the blue, Dr. Gerber, I have a patient that may be a doctor, or a patient says, the doctor thinks I have Lyme carditis. Which antibiotic should I use? And what I always have to say is I don't treat bacteria. I treat people, and everybody is different. Hence, my practice name is Bioindividual Health Strategies. You have to understand the host and the host response and what's causing their problems. But you may have Lyme disease, but very often we find that they have mycotoxins. Very often they have parasites. In fact, my experience in Mexico has really broadened my concept of parasites, because we have patients who've been to many fine establishments, very upper level clinics in Europe, and they got better for a while, and now they're sick again. And the reason they're sick again is because they have parasites that weren't removed. So the parasites, and this is known in holistic medicine, and parasites are a problem. We always have parasite cleanses, but it depends on how meticulous you are and compulsive you are about eliminating them. And the parasites harbor Borrelia, that's the organism for Lyme disease, but they also harbor viruses. And some of the parasites actually feed on heavy metals. That's why they're there. They will act as a sump pump to drain out some of the heavy metals and toxins. The parasites, that's their role, is to take them up. And so then if you do a typical parasite elimination program where you give them chemicals to kill the parasites, well, the parasites die where they are, and if they happen to be in your peritoneum, the parasite dies in your peritoneum, those toxic things are released and get redistributed.
And I'm just jumping in, Dr. Gerber.
Sure.
I know you know why, and probably most people watching this will appreciate that. I just want to keep everybody together with us, that everything we're talking about here, where we're going off on bacterial or viral infections or parasites and these things that are left inappropriately dealt with inside of our body, the core thing here is, it keeps coming back to the same premise, is going to cause a lot of inflammation. Low-level chronic inflammation, a fire is burning in us that is constantly putting injury to our arterial system. Here we are talking about heart problems, and we've got people focused in conventional cardiology on bypass surgery, stents, take blood thinning medications because you're clogged, and nobody is looking yet nearly enough to the totality of our environment. Like you say, you treat the human being. Where is the person getting so toxic? You were reminding me too, and I'll let you jump in then after I've gone on too long already, with Dr. Rao talking about Lyme disease. And why is it that some people get bit by a tick and they're fine? And other people, it's raging and it's terrible and even antibiotics don't work. It's the inner terrain. You could get bit by a tick and your inner terrain is strong and vibrant and your immune system is powerful and you're fine. Is that kind of, am I listening to you correctly?
Yeah, so we're kind of working our way there. And so the approach that I've taken is not that antibiotics are bad. I mean, antibiotics have particularly an acute early infection. That's when they're most effective. But when people come to me or get referred to me with symptoms of heart disease, they often have symptoms of problems with their brain. And if you look, probably liver, pancreas, we don't know how to look for all those very well. So at that point in time, it's not just the organism. You don't want to just kill the organism. You don't want to kill the person in the process, which I'm afraid can often happen. But you want to support. The idea is not to treat a disease or kill an organism, but there are therapies intended to support the person and their systems that they need. And a good example right now I'm going to jump to is statins again. So statins are basically derived from mycotoxins. I mean, to me, the hugest problem with mycotoxin poisoning in the United States are statin drugs. But along with that, we're not taught this, but the data is there that cholesterol, we need it, we can't lower it, but the lipoproteins, LDL, HDL, they're all part of our immune system. So in response to infections, the LDL cholesterol may go up because it's part of the immune system.
Wait. So this is huge. I'm so glad I have a holistic cardiologist here. I have said this before, but what does Jonathan know? That the idea that the presence of cholesterol, relatively speaking, keeps going up and up in an individual, it's not so much the one number, one day, one blood test, but if the track of an individual is the cholesterol keeps going up and up and up at an alarming rate over years, it could simply be the sign that there's a presence of infections or something causing injury to the body that's demanding that all this cholesterol rush to an area to sort of help it out a little bit so it survives. Is that true?
Well, so this is but I need to say that it's controversial. There, I think, is very good literature out there that cholesterol is not the enemy, and we need it. And the other thing about inflammation. So applying anti-inflammatories to heart disease has not worked out very well. And just putting out inflammation doesn't always work very well because inflammation is part of the structured healing response.
But what I was getting at also, though, just to kind of make this a clear point, what I've understood over the years talking to integrative healthcare providers, is this idea that if we're going to take statins then, when there are unaddressed serious issues inside the body of a person that's fully infected in one way or another, fully toxic, not changing the way they're eating. And now you're simply looking at a cholesterol number that's too high, definitely alarming. It's going to get everybody's attention, and just drop that cholesterol with a drug. Now, what about all those infections and all those problems in the body not being met with something to help counter its effects? It can be very dangerous, problematic in that person if the infections are still brewing, the cholesterol numbers dropped really low. Now what protects them? There's actually been literature, people have been saying to me how it actually increases the risk of cancer in the long run because of this way of quote unquote treating heart disease.
Exactly. So that's what I was saying. So in women, it's pretty clear that the higher the cholesterol, the lower the morbidity and mortality. In men, it's a little bit more neutral. But it's also shown that the lower the cholesterol, the higher the all-cause of mortality. So that's true. It's just not studied well. And when you say, well, that high cholesterol, it's alarming. Well, why is it alarming? We've been taught that it's alarming because most of the standard teaching that you see in medical schools and for cardiologists is that a high cholesterol is alarming. It didn't used to be, but it became alarming when we had drugs to effectively lower it. And effectively lowering cholesterol is not necessarily correlated with improving outcome.
No, but that's why I say I think this conversation is only crystallizing for me a very big, healthy perspective. It's really solidifying it for me that each and every person has to look at what they're being exposed to, what kind of toxicity they're being exposed to from their diet, their work environment, their home, the chemicals that they're breathing in, they're putting on their skin. The list goes on and on and on that could be causing so much constant injury to the system that causes cholesterol to go so high. So if we only look at cholesterol being so high, correct me if I'm wrong, if it's this kind of perspective that I think is much healthier, then we're missing the boat. We should be looking at what's driving numbers up or down in the lifestyle that we live.
Yeah, so to crystallize that for you, patients will ask me about statins, and I tell them I don't prescribe statins, but I don't stop them either if I'm not the one who's prescribed it, because I don't follow the cholesterol level in that way. And they say, what do you mean? They say, what's the best cholesterol level? And I'll tell them one that's not been measured, because it drives the whole investigation of what's wrong with them in the wrong direction. If you're focused only on what that cholesterol level is, then you ignore things that I think are more likely to be a problem. And my conclusions for this are that I think that stealth infection is probably a major contributor to a lot of illness in this world. And the fungi, the mycostatin, or the mycotoxins, which are products of the fungi, they've been around for a long, long time, and they're pretty intelligent creatures. And they must have read The Art of War, because they've learned that you can really be successful by being patient and gradually taking down your feast from the inside without causing a lot of disruption. So it does it very, very slowly, very continuously, and very devastatingly. And so I think that one of the major toxins in the world are fungi, but we're just now starting to appreciate the role of mold and mycotoxins in health. When we look at the cell, on the inside of the cell for toxins, we will find multiple mycotoxins in the cells. We'll find multiple chemicals. And babies now, they're born with, 300 or more chemicals in the placental blood. So the concept of toxicity to me is continually changing now with EMF. So the heart is an electrical organ. It has frequencies. Actually, our DNA actually sends and receives signals. So there are so many things that are disrupting it. So now we've got EMF everywhere. So that's another toxin on the heart.
Well, the simple concept of us being electrical beings is such a fundamental, okay, everybody would shake their head, yeah, of course. but yet somehow the conversation doesn't continue when it comes to somebody who doesn't feel well. If we are fundamentally electrical beings, we're spiritual beings. We're going to talk a little bit about that in a moment as well. But that all of the toxins that may be surrounding us affect us on an electrical level. So we should be looking at what some of those greatest assaults are, remove them, and wow, what a radical concept. Maybe our electrical system will start functioning better by just simply taking the stress away.
So stress is another toxin. So we've briefly talked about infections, obvious infections like Lyme disease, which is also a stealth infection. And another stealth infection we hinted at is in the mouth, so in the gums and the teeth, major risk factor for heart disease. Cavitation, so if you have a tooth removed and it's not removed properly, there can be a focus that could be hidden and not even painful that harbors these bacteria, and it may be the bacteria or the bacteria poop. And there's toxins, and it can drain into the brain or it can drain into the coronary sinus and into the heart. So that's another. Those are sources. We've talked about EMF, which is something that is becoming more of an issue with what's called electrosmog. That interferes with the electrical. People have palpitations and arrhythmias. So I have patients who have Lyme disease. No doubt they have Lyme disease, and they have palpitations. And palpitations, for those interested, is probably the most frequent symptom of Lyme carditis, but it's also a very frequent symptom of EMF. And so when I'm trying to determine what's a toxic heart, we've got to go through the list of toxins.
And just to be very clear for the new person out there, just on the EMF or electrical level, I'm doing organic food, I'm exercising, I'm trying some meditation, I'm taking supplements. Someone who might be check, why are you doing really well? What is this disturbance you're still having in inflammatory markers being elevated? And, you're just not out of the woods on a cardiovascular level. Poor electrical wiring in the house, smart meters that might be attached to your home to measure your energy, that might be strapped to the outside of your house, just outside your bedroom wall, cell phones, baby monitors, these wireless baby monitors, laptops, wireless routers, cordless phones.
Those are the worst, yeah.
The worst in cell phones. Living close to a cell tower or the 5G that's being deployed, and the satellites are in space, and then that 5G, those little towers are being deployed in a city where you might be. The list goes on, that if you're close enough and exposed to that a lot, they call them hot spots for a reason, that hot spot could be really driving your inflammatory markers up. Fair to say?
Yep. And so you mentioned Dr. Roll saying, well, in the same family, somebody could get bitten by a tick and have no problems, and somebody else in the family have a lot of problems. So we're getting to the topic of genetic predisposition, and you can have markers. They're called HLA markers. They're a set of chromosomes that have clusters of risk factors for Lyme, for mold, for EMF. So some people are more sensitive than others. And then people can have a genetic disposition based on their ability to metabolize toxins, and these are in the MTHFR genes and the cytochrome oxidase genes. And then there are genes that produce inflammatory compounds, cytokines, or counter them. So IL-10 counters inflammation, the IL-1, IL-6 produce inflammation. So you can imagine somebody who has a genetic predisposition where they're given genes that overproduce inflammatory compounds in addition to a bite or something, and underproduce the genes that put the inflammation out. They may be bestowed genes that are not as effective for defense. There's something, superoxide dismutase, and those are all genetically determined. So you may have genes that aren't as effective in producing the natural defenses, and you could be given genes that interfere with methylation, and you can have HLA genes for Lyme and mold and EMF in the same person. So just imagine somebody who's got that the hand of cards versus somebody in the same family who got a different distribution of genes. Thank you, Mom and Dad, but sometimes it's not always fair.
100%. The difficult cases out there, people who are really struggling and listening to this conversation, it may come down to really peeling that onion apart and getting the genetic testing and just other things to get that feedback, because that person you're describing just has to be really, really strict and precise about what they're doing to counter their tendencies, right?
Yeah. And then the issue of genetic testing is important because many people will get 23andMe. They'll order it online and it's great, or they'll have another doctor that does nutrigenomics. I started doing that 10 years ago. But then I discovered that this concept of epigenetics is you could have a perfectly normal looking gene pair, but you could have what's called a toxic adduct. It could be a pesticide, an herbicide, a heavy metal that's sitting on that gene and changing its function.
Okay, Dr. Gerber, great. Let's get into, though, now as we shift gears, we've talked in a big picture way about these things that can make the blood and our whole body toxic, which absolutely will in time damage our heart function. But now to give that message to people so that they know what's going on with me, that's what most people out there care about. What's happening to me? What are some of the tests that you're doing to sort of reveal the truth?
Okay. Well, that's a very interesting question for me because many patients that come to me with symptoms that they think are related to their heart have been to one or more cardiologists and their EKG is normal or minimally abnormal. They have the usual features on a Holter monitor where they record their heart and there's some extra beats here and there, but nothing special. They've had an echocardiogram done and the heart function is normal, the valves look okay. Some of them have had an MRI scan, and if it's not done in the proper protocol, it won't show what you want it to see, what you want to see. So a lot of times they've already had the heart test done, and it doesn't show anything, and they're therefore told that it's all in their head and to take Prozac or see a psychiatrist, but it's all in their head. Well, in fact, it may not be. So the tests I do, I look at more on the cellular and membrane function because that's where the action is. We were told by Bruce Lipton a number of years ago that we used to think that the body and our lives were controlled by our DNA, but in fact, it's the membrane that determines what happens. The membrane is what's in contact with the outside world and the nucleus, so the membrane can tell the nucleus which chromosomes to turn on or turn off. So I look at the membrane. And there's a way to actually do that. It's called the red blood cell membrane fatty acid analysis. It's done at Johns Hopkins University. And they can tell us what the composition of the red blood cell membrane is. And we use that as a surrogate, as an example of other cell membranes in the body. And there's some variability between organ and organ, but it's not much, very small. But usually the changes we see in the cell membrane are very striking. And there are patterns we see with a viral infection, for example, or with a bacterial infection. Inborn errors of metabolism will have some changes in the cell membrane composition. And then when we see that, then we know, we get an idea of what needs to be corrected. In fact, there have been so many of these done now that they can actually, based on the composition of the red blood cell membrane fatty acids, they can suggest inherited disorders of metabolism.
Wait. So let me see if I'm following you right. So in other words, it's not just looking at it like, ooh, it looks not healthy, like sort of like Emoto's experiments with sick water, right? Where people were surrounding the water and thinking terrible things and it just looked like sick water. But you're saying the fact that it also not only looks not right, in the way it looks, it tells you what's causing the injury as well. Is that true?
It suggests what's causing it. It doesn't always tell us exactly, but it suggests, could be viral, bacterial, fungal, could be something else. And it also will suggest certain inherited diseases of fatty acid metabolism, which could affect the cell membrane. So in essence, instead of looking at the genotype, so if you look at a gene test like 23andMe, you're looking at the gene pairs, but those gene pairs may actually be normal, but have something on top of them causing the gene function to be abnormal. So we're looking at the phenotype, not the genotype.
And not to lose anyone out there, I hope,
Okay.
but we're talking directly about something that would impact a cell's ability to take in nutrients. Just correct me if I'm wrong. I'm going to go through a couple of things in my mind. To take in nutrients, to get rid of waste, the energy of a cell, the energy of our heart, our emotions as well could be affected, all by the functioning of a cell. If it's gone more dysfunctional, it can affect a lot of these real practical things in our life, right?
Exactly. So by knowing the composition of the cell membrane, we can get some information about what's causing that abnormality of pattern, and also get a more discrete idea of how to appropriately treat the patient.
What other kind of tests
Okay.
do you find are useful?
So I pair that with a test. It's called the IGL. It's the name of a factory or a company in Germany. And this looks at, by using electron microscopic imaging of the elements in the DNA and in the cell membranes, it can tell what's there that doesn't belong there. For example, it's like what they use for CSI, the forensic studies, when they want to find out if somebody's been poisoned. They do this microscopy that makes certain things show up with a certain color. So they do that on an electron microscopic level, and we can see that there are heavy metals, herbicides, pesticides, antibiotics, interfering with cell membrane functions or DNA function. And based on that, we can get an idea of what needs to be done to improve that. So we can do a generalized detox program, for example, but if you know that there's PBA in there versus something else, that maybe you would tweak one of the therapeutic arms more than another. And then for mitochondrial function, people, and I do the same thing, I'll give people CoQ10, ribose, acetylcarotene. I'll do the whole mitochondrial protocol, cocktail. But if there's something interfering with mitochondrial function, such as a toxic metal or something that doesn't allow the mitochondrial function to work, you can throw all that stuff at it, but if there's a cog in the wheel and the wheel doesn't turn, you're not going to get the effect that you want.
Right, see, you're crystallizing it for people on a cellular level. This is where the dysfunction is. And on a practical level, this is the frustration for so many people out there listening. Hopefully they see the answer now. They're eating organic salads, they're exercising, they're trying to change their lifestyle, and their energy is still down. Well, hello, maybe they didn't look at their heavy metal toxicity. So these guys are acting like bullies, pushing out all the nutrients, and so everything you're trying to do is not taking effect yet because you haven't dealt with this one thing that's blocking good things from happening to you.
Right. Yeah, so people will do, I don't recommend doing testing for metals as much as I used to. Because with this test, you can find out not only that it's not metals in the blood, it's metals in a cellular organelle that's causing the damage. And some of them may not be detected using these other tests. So it does help as far as the heart goes, because the heart's an electrical generator, and it has all these, you have much more mitochondria in the heart, and the mitochondria need to be able to work. So I use these two tests are very helpful. And then as far as membrane composition goes, there's a lot of misinformation or difficult to understand information out there about, for example, fatty acids, essential fatty acids. So yeah, so there's people are being advised to eat large amounts, relatively large amounts of omega-3 fatty acids, fish oils in particular, and to minimize omega-6 fatty acids because they're dangerous. They're both essential fatty acids. Now, omega-3 fatty acids from fish oils, if that's what you focus on, there are omega-3 fatty acids that are at the lower level, the fundamental omega-3 and omega-6s that are essential fatty acids. And although they aren't metabolized well to the higher omega-3s, people tend to not eat the lower level ones. Such flaxseed oil is an example.
Right, this is a good point. And it's not that you're I don't want people to misunderstand that you're encouraging people to eat all those omega-6s, though, on the other end of the spectrum, from vegetable oils, though, in bagels, crackers,
gonna
and
get to-
cookies and all these things. They still have to be careful not to eat all those vegetable oils that really throw them way out of balance, right?
Yeah. So the difficulty these days is that, in fact, I've heard that people shouldn't eat seed oils because they're dangerous. It's how they're prepared. So the commercial seed oils are often done with high heat. And now if you look at, for example, safflower oil, a lot of it is high oleic safflower oil. So it's an omega-6, but it doesn't have the same impact metabolically. So you have to be careful about the omega-6s and the omega-3s. So the omega-3s, if they're processed with high heat, as most of the commercial brands are, they're toxic when you open the bottle. In fact, some of them are flavored with lemon juice or lemon flavor, and I think that's so that you don't taste the rancidity. So the omega-3, you need less of it, and it should be cold pressed, cold processed.
Right, so it's very important that people understand it's not even necessarily from what you described, the actual substance, which gets demonized or not.
Exactly.
But more importantly, it has so much to do with the source in which you get all of these substances that are truly needed for life. Where are you getting your fats from, sugars and all these things? And stop oversimplifying things for sure, right?
Yeah. So I think in general, and we'll talk about this maybe later, but I recommend a diet that's really got natural, getting your food from natural sources as much as you can. And that's kind of the ultimate goal. The reality is, if you're living in a big city, it may be hard to find those. And you can go to a certain store where things are labeled organic, non-GMO, when in fact they're not organic and they are GMO. So it's reality is that it's difficult to do this. But we need to keep in perspective that there is misinformation out there. So you do need omega-6 fatty acids, and you need to have them in a right proportion. And you need to have omega-3 fatty acids, both the plant-based, which would come from something like flaxseed oil, and the animal-based omega-3. So we need those. They're essential fatty acids in order for our cells to work properly. But it's critical to not avoid omega-6 completely, because that is the essential fatty acid of life. That's what makes our mitochondria run. And what people don't realize is that these fatty acids vibrate. They vibrate like, I don't know, like 1,000,000 times a second or something. Very, very fast speeds. And when they're improperly processed, or they have the wrong combinations like the high oleic oils, then that vibrational speed slows down. So we need to have that for the heart to generate energy. And then the other thing is the membranes themselves. The cell membranes are fantastic engineering manifestations of life. They're composed in a certain way that it can store electricity and release electricity. So it's the phosphatidylcholine and the lipids form a insulator on the outside and a conductor on the inside. And so this is another essence of life, that we can generate and store and release electricity.
Before we get off this topic, for people wondering out there, what's a good source of omega-6s then, if it's not from Doritos chips?
Well, a good source is directly from the seeds. And so, I've heard people say, "Oh, seed creams are bad for you. Seed oils are bad for you." They're not. I mean, if it's from the seed and the seed is not covered with herbicides, pesticides, and pollutants.
So to be clear, really good quality. The pumpkin seeds, the sesame seeds, things like this are good.
They're good if they're not covered with. And that's the problem. What's the source of those seeds? And then for the oils, that's another problem. There are very few good omega-6 oils. So if you're a healthy person, you can get away with a lot. And if you're healthy and your metabolic and methylation pathways and detoxification pathways are intact. But if you're sick, then you really need to do what I call a therapeutic grade oil. And there's one or two companies that make and produce healthy oils. one that comes to mind is called Membrane Health. And they have oils and products that were developed for babies with inborn errors of brain metabolism. So if you want to be correcting a neurologic problem in a baby, you have to be pretty sure that you're not putting toxins into their brain. And so there's a line of products that are very, very pure. So I use them for adult patients in whom I want to have a therapeutic effect of food. So that's a food source of a therapeutic agent. And the other component is phosphatidylcholine. And there's a lot of difficulty out there understanding what phosphatidylcholine is because the FDA allows a manufacturer to label a product as containing or being phosphatidylcholine even if it's lecithin. And so there's a difference between lecithin and phosphatidylcholine. So it's the amount of phosphatidylcholine. So you want it to be 50% or more. And phosphatidylcholine is vital to life. I mean, people don't think about this, but it's a major component of the mucous lining of the intestines. It's a major component of surfactant in the lungs. And it's a key component of all cell membranes. So we need phosphatidylcholine. There's a couple companies that make phosphatidylcholine, and there's one company that has kind of a bioidentical phosphatidylcholine. So phosphatidylcholine is one, it's a phosphate head with lipid tails, but the tails can be different combinations of saturated or unsaturated fatty acids. And there's one company that has the proper mix of, these are some technical terms, but phosphatidylcholine, phosphatidylethanolamine, phosphatidylinositol, and phosphatidylserine are all components of a healthy cell membrane. And there's a company, again, Membrane Health, that has figured out how to create that particular product. But there are other products that have primarily phosphatidylcholine. And if you want to use phosphatidylcholine in your therapeutic regimen, you want to look at the label carefully and make sure that it really is phosphatidylcholine and not just lecithin.
And again, all of this is just to build up better cell integrity. That's what this is all about. Get away from the toxins and build up integrity.
Right, so the cell membrane, so the key for the toxic heart, and getting into all this about the construction of the cell membrane, is that you want to have a cell membrane that has the proper electrical potential. So when we talk about holistic cardiology and people are looking for supplements, they're looking for biochemistry. But actually, it's the physics that drives the biochemistry. So you want to have the appropriate electrical potential in the cell membrane. If you have the right electrical potential in the cell membrane, for example, if you have an imbalance of, there's another phospholipid called sphingomyelin. Sphingomyelin is too high, which happens with aging, and the phosphatidylcholine is too low, it attracts calcium, causes calcium in the artery wall. You can reverse that by giving phosphatidylcholine and reversing that ratio. So for a toxic heart, you can actually reverse inflammation and reverse the calcification without doing traditional chelation where you put a chemical in to pull it out. You can do it by changing to a healthy electrical potential of the cell membrane, which pushes the toxins out.
Wow, it's amazing. You're talking about changing the inner terrain, just manipulating things to make it so that you become a healthier electrical being. It's great.
Yeah, and that's the whole point of this toxic heart, is that we are electromagnetic beings. We all have electromagnetic fields. For example, right now, we are each in each other's field. Get a little farther away, we're outside, but it goes 3 to 6 feet. People who are really sick, and I actually measure their field. I do it with simple things like a pendulum or a tensor, but there are ways we can measure people's fields. And if your electromagnetic field is weak, you're weak. So where does it start? It starts really at the cell membrane.
And we got to surround ourselves with good people.
Yeah. Well, that's another. So for a while we wanted to talk about emotions, and so there are toxic emotions that will affect the heart. And people will talk about my heartfelt emotions. You know, you're in my heart. Well, there's a reason for that. Because the heart may be, I think it's the seat of emotions. Some people think it's the brain. I don't know. and people will talk about they have a mind to do something. You know, I've got a mind to do something. Well, is the mind the same as the brain? They're not. There is no spot in the brain where you actually call a mind. The mind, your mind to do something is your thoughts, your collective thoughts, and your being and other things. So I think it could exist in the heart, not in the brain.
When I think on an intuitive level, anyone listening to us right now totally gets what we're trying to say here in terms of changing us, our inner terrain, so we become better electrical beings, and so that we can get the most out of our diet, our supplements, our whole life, that the way we think will affect our heart and our emotions, and the way we feel on a chronic level, constant level, is going to affect the way we think. And if we just get more mindful, is the way I put it, to everything that we're talking about here, use our head a little bit more, that can have a lot of positive effects on our emotions and our whole physiology, if you will, our chemistry, and our risk or our lower risk of heart disease, just by being careful about the way we feel and the way we think about things. Making those changes certainly can change us on an electrical level, no?
It can do it very quickly. So one of the tools that I use is heart math. You may be familiar with that. It has to do with breathing, and we call it coherence and how you're thinking. And if you have appreciative, loving, caring thoughts versus chaotic, angry, frustrating thoughts, you can actually change what's called the heart rate interval, the way that your heart responds to your thoughts.
Conventionally speaking, this would sound nuts, but here it is, we're talking about literally changing the way we feel and we think can change our electrical rhythm. Everybody out there feeling stressed out, irregular heartbeats, worried about having a heart attack, it all comes down to what we're talking about here.
Yep. So the heart has such a large electromagnetic field, much larger than the brain. So we all know the brain is very important. It's, you know, it's a very electrically active, and we can actually look at the types of frequencies of different parts of the brain with very sensitive devices called an EEG, for example. And the heart's really simple. It's an EKG. You know, we don't look at all the different waveforms from different parts of the heart, although we could. But the heart is more powerful than the brain. And sitting here in each other's fields, under the right circumstances, I can have my heart impulses and train your brain impulses. And depending on, so that has to do with people and their talking and their, what we call coherence. So we can influence each other's fields in ways that we haven't thought about, and there are people who are so-called healers who have learned how to use these electromagnetic fields and these thoughts, but for a benign way.
Well, I think on an intuitive level, again, you're striking something that makes sense to a lot of people. If you're in the presence of someone and you feel sick, is it the way that person that you're in front of is thinking? Is it the way they're feeling? Something strong is coming off that person to make you feel really good or really sick. That's an invisible electrical thing, an impulse, if you will, that is being sent out by that individual, and you as an antenna, you are picking it up. This
Exactly.
is not woo-woo weird stuff. This is real.
It's absolutely the truth. And so a toxic heart can manifest itself through these palpitations, which interfere with our heart, or interference with our heart rhythm. But a more dramatic is what's called Sakotsubo. There's a cardiomyopathy, a stress-induced cardiomyopathy, where people will actually have something like a heart attack, but the arteries are open. And it's known as a stress-induced cardiomyopathy. It happens more often in postmenopausal women, but it can happen in men or other people.
Meaning that sudden jolt of a
Stress.
serious event that can really bring someone literally down to the floor.
Right. And it may not be a momentary event. It might be stress over a period of time. But it's a stress-induced, it's felt to be partially a stress-induced heart attack or cardiomyopathy, which can be reversible. So that's an extreme, well, and then sudden death. I mean, people can have sudden death from emotion. So emotions are important, but there's another aspect that most people don't think about, aren't even aware of, and that is if somebody is a recipient of a heart transplant, some of these people will pick up the memories, emotions, characteristics of the person whose heart they have received. So if all of our thoughts and cognitive issues are in the brain, then how could that be transferred via somebody's heart to another body?
And also on a practical level, I don't know how many people have heart transplants watching us, but also you just made me think about how important this is, that everybody in the family get on the same page about what it is we're talking about here, because the real effect of family, the way they think and feel about what a heart patient may be going through, the negative things that they're struggling with, that they need help with, or the positive things that the heart disease patient needs to do. And if the person that is sick is not getting the support of those around them, those messages, those thoughts and feelings, that's affecting the person's own personal health as well as maybe a physical heart that may be coming from somebody else.
So exactly. So when we're dealing with the most toxic people, the people that come to this hospital that I work in now, I'm very fortunate to be able to work with them. People are physically toxic, and the secret, it's not really a secret, I mean, the way to get those people healthy is to do detoxification. I mean, the first thing we've got to do is get their bowels moving. I mean, as simple as that. If they're constipated, it won't work. But then we need to detoxify them on the cellular level. And then what we talked about, family relationships, we call family constellation. Getting rid of unresolved conflicts, emotional blocks. If you don't correct that, then they won't heal.
I hope you enjoyed day 5 of the cardiovascular docu-class. Stay tuned because we still have 3 more days and the best is yet to come. By the way, if you'd like a copy of these episodes plus all the other presentations offered inside the cardiovascular docu-class, simply click the link below and choose the package you want, including some really valuable bonuses. Talk to you soon. Take care.